Chapter 4, Modalities in Data Acquisition. The purpose of this chapter is to discuss the attributes of acquisition devices used in radiology, discuss the basic issues and themes that are commonly seen in imaging modalities, and to explore how each modality should have optimal image quality and performance. Modalities are considered the image engines of PACS. So without modalities, we don't even have the pictures that we would need to put on PACS. Radiography comprises 60 to 70% of all PACS studies. Cross-sectional modalities are quickly becoming the examination of choice. And as we've discussed a little bit earlier, cross-sectional modalities include CT, MRI, ultrasound, and PET. So while it is great that cross-sectional modalities are becoming the modality of choice for clinicians, it also poses a problem because the images from their studies are a lot larger than a regular radiography study is, which means it could create issues when it comes time for image display and archival. Now, in the PACS world, the system is only as strong as its weakest link, so every part of it has to be up to speed and work at top efficiency. And this also includes the image display and archival. All right, now I want to talk a little bit about general radiography. Usually today there are two types. There is computed radiography, which is CR, and digital radiography, which is DR. I'm sure you all know this already. You won't see a lot of places still left out there that are film-based. CR is cassette-based, and it is the direct replacement for film screen. It uses existing radiography equipment, so the tube, the table, the bucky, that is all existing already that a department had previously used in the film world. It is known as photostimular storage phosphor, or PSP, radiography, and the nice thing about CR is that it allows for flexible positioning. With digital radiography, there is an integrated detector that doesn't require direct user handling to acquire and display images. So you put the detector where it needs to be, you take the exposure, and the image will show directly up on a monitor in front of you without having to run the cassette. The image size depends on detector element dimension, field of view, and bit depth. The nice thing about digital radiography is that it has a higher patient throughput than CR does. The bad thing about the good side of digital radiography, so it's nice that it has a higher patient throughput, but what you're seeing nowadays is that it often eliminates the need to replace text. So it is so efficient that it actually allows the department to run on a lower staff level sometimes. If a site is considering either to purchase CR or DR, they need to look at themselves and see how they work in a few different categories. Choosing between the two usually depends on a few things, such as needed throughput, the types of studies to be performed, flexibility of positioning, and existing infrastructure. So for example, if you work at an outpatient clinic and it's, say, mainly an ortho clinic, you're doing a lot of axillary shoulders, you're doing a lot of cross-table hip imaging, and you want to think what is best for your department if you're going from film-based to either CR or DR. With those types of exams, you need flexible positioning. You need to be able to get the detector behind the shoulder to get the axillary shoulder. You need to be able to have enough room to get the detector into the crest of the hip for the cross-table hip. And this just isn't as doable with digital radiography as it is with CR. So in that type of situation, it may be best just to opt for the CR option. However, if you work in a larger hospital, you probably have a high patient throughput. So in that case, you may want to opt for the digital radiography option. All right. We're just going to talk a little bit about digital mammography and fluoroscopy as far as data acquisition goes. So for digital mammo, either CR or DR is used today. Film bases has gone by the wayside. Mammography is governed by the Mammography Quality Standards Act, which is MQSA. It is often used in conjunction with computer-aided detection, or CAD. CAD basically uses algorithms used to process the raw image data. With digital fluoroscopy, real-time x-rays are used for dynamic evaluation of patient procedures in diagnostic and in interventional radiography. Sequences of 1 to 60 frames per second are taken, and the images are stored individually or as videos. Fluoro sequences aren't usually archived, but spot images and digital subtraction are. With digital fluoro, it requires a third-party DICOM interface box to capture images for archiving. So an example of this is a TIMS unit. It basically captures the fluoro sequences and archives them itself. With CT data acquisition, the machine actually acquires thin slice projection data using a rotating X-ray tube and detector array, which we've already discussed. It produces numerous tomographic images of anatomical volume by computer reconstruction algorithms. Window width and window level settings, they provide instantaneous translation of image grayscale on the display. So window width is the range of grayscale values portrayed on the image, and window level is the average brightness settings of grayscale values. So just to put it in perspective, with window width, a larger number means a wide latitude or a low contrast display. There are CT numbers that are used with data acquisition in CT. These are called Hounsfield units. They indicate X-ray attenuation of different tissues in the body. The Hounsfield unit usually ranges from a negative 1,000, which is air, to 0, which is water, and to 3,000, which is extremely dense bone. We've talked about this in a previous chapter, so this might be just a little bit of a review for you. Spatial resolution and contrast resolution are important factors in data acquisition of CT. Spatial resolution is dependent upon slice thickness, which is the z-axis, and reconstructive field of view, which are the XY plane dimensions. With contrast resolution, it is dependent on the number of X-ray photons per voxel and radiation dose. CT acquisition techniques depend on patient size, so pediatric versus adult, and a type of study, head versus body. Technique includes factors such as KV, MA, time, slice thickness, and so much more. Multi-detector row scanners acquire multiple slices per X-ray tube rotation. Some examples are 16, 64, 128, 256, and even up to 320 simultaneous slice acquisitions. You may often hear of a CT being referred to as a 16 slice or 64 slice. This is in reference to slice acquisitions. In relation to PACS, study splitting in CT is important for assigning specific accession numbers associated with each type of exam. So, for example, a doctor may order a chest, abdomen, pelvis exam all in one. Well, for PACS purposes, the chest needs to be separated from the abdomen and pelvis, and each of them need to be having separate accession numbers. Moving on to MRI and MR spectroscopy. MRI is an imaging procedure that uses a strong magnetic field, usually 1.5 to 3 Tesla, to magnetize protons and tissues of the body. Remember, the hydrogen atoms are important with this field. T1, T2, proton density, blood flow, perfusion, and diffusion are tissue characteristics used by MRI to manipulate tissue contrast. Pulse sequences are very important with MRI. It is specific timing methods used for applying radiofrequency excitation and magnetic field gradients to achieve desired image contrast and anatomical presentation. Just like in CT, contrast is also used in MRI. The contrast enhances the MRI images by using magnetization properties of gadolinium, which is the contrast used in MRI, to change tissue contrast based on T1 and T2. MR spectroscopy analyzes tissue characteristics of metabolites in single or multiple voxels, which are volume elements. This is a method to non-invasive biopsy indeterminate tissue areas in the MR image. One very important part of MRI is that safety training is absolutely required for personnel working in and around these areas. I'm sure you've heard a few horror stories involving MRI, maybe someone bringing a non-specific MRI wheelchair into the room, or possibly an oxygen tank being brought into the room. These are major issues, and safety training is something that helps prevent these errors for the personnel working in MRI. Effects of strong magnetic fields, fringe fields, radiofrequency excitation, heating, and dangers of ferromagnetic materials must be known for the safety of the staff and also for the patients. MRI also has artifacts, just like CT. A Faraday cage is a copper mesh plate that encloses the MR room to create an environment that is free of radiofrequency signals. So it kind of encapsulates the MRI room. Ultrasound is another modality that requires data acquisition. With ultrasound, tomographic images are generated by using acoustic properties of body tissues, by sending short, high-frequency sound pulses into specific volume, listening for echoes, and creating anatomic grayscale images. Moving on to nuclear medicine. Nuclear medicine imaging uses tracers tagged with radioactive materials that are injected into the patient and are then redistributed according to the metabolic activity in the different areas of the body. Different types of nuke med machines are the single photon emission computed tomography and the positron emission tomography, also known as the PET scanner. So with the single photon emission computed tomography, it records planar images that form multiple angles and use images to reconstruct tomographic slices from the image volume. Then there is PET imaging. So this uses positron emitters to produce annihilation photons. Positron emitters are elements that decay and release a positive electron and are attached to a metabolic agent. These elements that are attached to the metabolic agent are then redistributed throughout the body. All right, there is a system out there that is kind of a combination of a PET scanner and a CT scanner, and it is named the PET CT system. So the CT part of the system provides attenuation correction measurements for improving quantitative accuracy of the PET uptake information, as well as high-resolution anatomy display. This kind of system provides both the physiologic and metabolic information and high-resolution anatomical and structural information. This is now a standard. There are a lot of facilities that have PET imaging, and the type of machine they have is a PET CT system. Now on to quality control. Quality control frequency is implemented as a function of the likelihood of finding a problem. So system components or human tasks that fail infrequently actually don't need to be tested as often as components that do fail frequently. Imaging professionals should be able to recognize problems that are specific to each modality and understand who to contact to solve the issues. So, for example, if you are a tech that has to perform the QA for, let's say, the CT machine every morning, and you're noticing that the standard deviation seems to be off a little bit, who do you contact? It's important that you know who. In this situation, you would contact, most likely, the service engineer for the vendor of the CT. Quality assurance asks the question, are we operating the devices correctly? And quality control asks the question, are the devices operating correctly? A key thought to take away from this lecture is that continuous quality improvement is a key factor for acting on QA and QC findings to strive for optimal patient care.